Hello, this is John Kanelopoulos from Athens, Greece, and I'm very excited to present to you a very interesting case. This is a 57-year-old gentleman who had a history of a penetrating eye injury in his left eye since the age of 7. Very important point. This happened at age 7. Until then, a very normal child, no glasses, no strabismus. He had spent all his life with that eye being extremely poor in visual acuity, and as you will see in the pictures to follow, he has a almost horizontal scar at the superior part of the cornea, which had involved some iris and is generating about 3 diopters of chorometric astigmatism. Fortunately, that penetrating trauma has not affected significantly the lens suspension by the zonules of Zinn, and at this point has developed cataract, as you will see in the video. So we opted to go ahead with clear cornea cataract surgery, in which we had pre-planned to use a toric intraocular lens to correct both the myopia and the significant traumatic induced astigmatism. I thank you very much for your attention, and please pay special attention to the marking and the position of the lens. We will pre-mark on the 9 o'clock and the 3 o'clock meridian at the limbus and use that as a guide to marking the actual axis, which happens in this patient to be 180 degrees, same axis, surgically. I thank you very much for your attention. Here is the significant trauma, as you can see here. It's an oblique superior cornea scar causing significant astigmatism and some ectropia of the pupil. Irregular astigmatism on the topography, more detailed here, how that flattening effect of the perforating injury is causing normal cell counts. And here the wavelight biograph interferometry, the IOL, toric IOL calculator, and again the interferometry numbers and how the final calculator gives us axis and power of the lens. And this is a surgical view, what we use in the OR. Here we are in the operating table. You can see the significant superior scar in the cornea, perforating scar. We had pre-marked the 9 o'clock and 3 o'clock position, as I mentioned before. We're going to use the axis marker to get some better visualization of the 180 degree meridian. 275 keratome, enter at the 9 o'clock position. Use the same keratome for only a ½ millimeter incision in the opposite direction. Copious viscoat here to protect the endothelium. By the way, the endothelial cell count, as you saw previously, is normal. Cystotome to begin the capsulorhexis. Visualization of the superior part of the anterior capsule is quite difficult. That's why we're going to be especially careful with our capsulorhexis forceps here to attain a capsulorhexis of about 5 millimeters with toric intraocular lenses. And specific with the Acrosoft toric lenses, I like my capsulorhexis to be a little bit smaller than my usual 6 millimeters in order to make sure that there is no movement of the lens in the capsule bag. After hydrodissection, the lens, as you can see here on a 57-year-old gentleman, is not quite hard. It's quite easy to remove. It's mostly cortical changes. We will remove with high aspiration here the last remnants of the lens, and with the split irrigation aspiration we'll go in and remove the residual cortex, polish the underside of the anterior capsule. This is our lens here, plus 17 power, 3.75 diopters of cylinder at the intraocular lens level. We'll place the injector and have the lens unfold, the typical very gentle and nice unfolding of the Acrosoft material. You can see the little markings on the right of your picture, alignment to the axis, and this is resure ocular bandage to ensure closure of the incision, something very important in toric lenses, as ingress of fluid may change the lens position. Thank you very much for your attention.